Half of Medicine 5, Uncertainty. So I'll be discussing 3 cases and then I'll be correlating with each other and then I'll come to the diagnosis. So starting with case 1. So case 1, Mr. X presented, a 26 years old gentleman from Vellore, presented with ulcerative skin lesions for 1 month, fever for 10 days and breathlessness for 1 day. So on examination, the relevant findings I will be mentioning, pulse rate, he was tachycardic and tachypneic with at presentation BP of 70/50, which was fluid responsive. However, in ward when he came, he required inotropes with respiratory rate of 36 breaths per minute and saturation of 90% with room air. His sugars at presentation was 56. Other relevant examination, chest examination showed bilateral extensive crepes. So this was a case 1. Case 2 is Mr. Y, 24 years old from Chittoor, presented with worsening sensorium and for 1 week and fever for 3 months. He had been visiting other hospitals with investigation, but the cause of the etiology of the fever was not being found. So with history of left foot pain, however, for the past 2 days, he developed left foot pain and swelling. Examination on general examination, he was tachypneic with saturation of 99% on room air. He was febrile with 100 degrees Fahrenheit. BP was 104/60. Pulse rate was 146. He was in a confused state, GCS of 14/15. His left foot on local examination showed increased warmth, discoloration, and blebs. And coming to the third case, Mr. Z is a 32. So first 2 cases are young patients, and the third one is an elderly, middle-aged, 32 years old, from gentleman from Tirupattur, presented with fever on and off for 1 month and right elbow swelling and pain for 15 days. With presentation of dehydrated, pulse rate 100. With local examination of right elbow and bilateral knee joint was suggestive of septic arthritis with swelling. There was initially there was not warmth, but during the day 3 of day 4 of admission, it has become warm and tender. The tenderness increased and there was restriction range of motion. So other systemic examination was normal. So just summarizing, so Mr. X came with fever, with acute onset fever with breathlessness, with a probable pneumonia with septic shock. Mr. Y presented with necrotizing skin tissue, soft tissue infection with low sensorium with septic encephalopathy. And Mr. Z had presented with probable septic arthritis with shock. So given these 3 cases with presentation in southern part of India, anyone would like to go for any differentials? So I'll just go with the investigations. So Mr. X, his presentation showed a pancytopenia with leukopenia and a platelet count of 62,000. He also had a renal function derangement with creat of 2.84 and liver function was transaminitis with a total bilirubin of 2.9 and direct of 1.5. His chest X-ray showed multiple homogeneous opacities bilaterally. His ABG was also suggestive of a ARDS. PF was 190, and his blood culture grew melioidosis, Burkholderia pseudomyelite. The second case is Mr. Y, who came with a NSTA infection with low sensorium with probable septic encephalopathy. He also presented with pancytopenia. However, his renal functions are normal. His INR was 1.32. We did an imaging of the brain also was normal for him also. So he presented with a PUO kind of picture with history of fever for 3 months and with decreased sensorium for the 2 days with an NSTA infection which he developed 2 days over. So his blood culture also grew Burkholderia pseudomyelite. And Mr. Z was a 32 years old gentleman. He presented with a septic arthritis kind of clinical presentation with synovial fluid aspect showing increased counts. And later we did a culture of the synovial fluid which actually grew, which grew Burkholderia. And his blood culture also grew Burkholderia. So, just in gist, I'll be so Mr. X, his melioidosis presentation was pneumonia with septic shock. Mr. Y was septic shock with encephalopathy, and Mr. Z was septic arthritis with multi-organ dysfunction. So I'll just talk briefly on melioidosis. So Burkholderia pseudomyelite is a gram-negative environmental bacteria, and mostly found restricted in the Southeast Asia and Northern Australia. So these are the regions where it is most commonly found. And in India, from the reports 1991 to 2018, the southern coastal region of Karnataka and Tamil Nadu has represented almost 80% of these cases, of which the Udupi district has been the highest reported annual incidence. clinical presentation varies. So it involves multiple organs. CNS, starting from CNS, where our second case was Mr. Y. He had brain abscess, encephalomyelitis. In our first case with pneumonia and septic shock, he also during a bedside echo was found to have vegetations on the valve. However, unfortunately, within 2 hours of admission, he succumbed to his illness. So cardiovascular manifestation, pericarditis, mycotic aneurysm, bacteremia, urinary tract infections, acute pyelo, kidney abscess, prostatic abscess, head and neck infections, respiratory infections, GI, skin and soft tissue, where our second case came with an NSTI infection, and the third case came with a septic arthritis. So the comparison of the southeast region, we find that fever and pulmonary infection and soft tissue infection are the most common ones in all the 5 regions. And comparing the risk factors, of which it was found that diabetes and renal disease as well as alcohol excess were found to be the major contributing factor for this melioidosis. This is a cohort study which found that the diabetes and hypertension was found to be the major contributing factor, and was done in South India between 2011 to 2020. And this is another retrospective study in which they have it has shown that the major risk factor of epidemiological risk factor of soil and water exposure with diabetes mellitus and renal failure. And there is a case report where they have compared the 2 arms, in which one received open arthrotomy and another didn't receive open arthrotomy in a melioidosis or septic arthritis, and it has been found following the arthrotomy there was significant clinical improvement. So the treatment, in short, consists of 2 phases: intensive and eradication phase. Intensive phase, so patient presenting initially, patient is not sick. We can start with the ceftazidime and wards. However, in ICU stay, meropenem is most preferred. Neurological involvement, if it is there, then meropenem double dose is preferred. However, eradication phase consists of 12 weeks, of which if there is a neurological osteomyelitis septic arthritis, we start septan from the beginning itself. So these are the different strains of melioidosis. And coming to our patient, so Mr. X, the risk factor involved for him was he was an IV drug abuser for 6 months with alcohol consumer and HCV positive. Mr. Y had no comorbidities, and Mr. Z was an uncontrolled diabetes and had a joint aspiration from outside hospital. And so Mr. X, unfortunately, succumbed to within 2 hours of admission. Mr. Y was initially had a worsening respiratory distress, was in shock, was intubated, and was on inotropes. However, currently the patient is fine, has been shifted out from ICU. And Mr. Z, so post arthrotomy, he worsened and he was intubated and was on inotropic supports. He was tapered, but he is also currently stable. So my learning point is a clinical spectrum of melioidosis and the risk factors contributing to.
Any questions?
The period of presentation for these 3 cases.
So the first case was an acute presentation within. So the thing is, in the same month, the last month itself, all 3 cases have come, and probably due to the soil and water exposure and occupation. One was the driver, another was a farmer, and another one was a farmer, and one was businessman.
What business did he do?
Sorry, ma'am.
What business did he do?
I'm not sure exactly of the business.
Because usually it is renal failure, diabetes, and farming. I mean, exposure to that type of water.
Started on
meropenem, yes. All 3 were started on meropenem. Repeat cultures, yeah, we have each patient have taken 2 cultures. Both of them grew Pseudomonas. Yes. No. Initial presentation itself was a very sick presentation. We started with peptides and we immediately upgraded to meropenem.
Eradication phase and intensive phase.
Yes.
One was dead, so that's finished. The other 2?
Ma'am, the other 2 is currently on meropenem, and they're continuing Septran. Yes, and both of them are coming out of ICU, and both of them are stable.
Only one thing. The intensive phase starts from the negative of the blood culture. So whenever we get a negative blood culture from the day of that day, we have to start the intensive phase and after the eradication phase. This patient started on Septran.
The third,
Both?
Both the Y and Z, both the patients were started on Septan initially.
The first one also had some skin.
Yes, ma'am.
thing, no?
Skin lesions. Yes, ma'am.
He did have some skin
Yes, ma'am.
lesions.
Any osteomyelitis for the third patient?
Yes, he got an ankle and a knee involvement, of which the ankle was becoming worse and had undergone an arthrotomy and debridement.
That is only septic arthritis. No?
Yes, ma'am,
He's
septic.
asking osteomyelitis.
Osteomyelitis, there was some bony involvement.
Anyway, wherever there's pus, you have to
Pus.
drain it. You cannot be doing it by conservative management. Okay. Any other questions? Anybody else? Okay. Let's take this. Next one.